So welcome everyone. Thank you so much for joining us tonight. My name is Christine Muir. I am the community librarian at Cary Library. And I'm very happy to be welcoming you to tonight's program, another in our Science and Economics series. All of our programming at the library is made possible by donors to the foundation. So thank you very much to everyone who's contributed. I am recording tonight's program. I will post it to YouTube after we finish, and I will send all of you the link to that. You are welcome to share that with anyone else you think might be interested. Something new tonight, we now have the option to offer closed captioning through Otter AI and through Zoom. I'm going to give you a very brief introduction to that right now, and I'll put more instructions in the chat when I finish. You can enable Otter AI in the top left-hand corner of your screen. It's a red live button. Or you can enable Zoom subtitles or transcript from the closed caption live transcript button at the bottom of your screen. Again, I'll put more into the chat if you're interested in that. And if you have any questions, you can ask me through chat. If you're not able to make it work tonight, you can turn on captions in YouTube. So that is your backup plan. We will have time for questions at the end of this presentation. If you would like to put your questions into chat, I will read them to our speaker. And if you would like to ask your question verbally, just use the raise hand button and I will call on you. Or put into chat that you'd like to ask it, and I'll call on you so we don't speak over each other. Tonight's program is part of our series on science and economics. It has been my distinct honor and pleasure to work with Mr. George Burnell on these programs for the past 3.5 years. They occur several times a year, and they always feature really interesting speakers who are your neighbors. I will now turn over this virtual microphone to George so that he can introduce tonight's speaker.
Welcome to Cary Library's Science and Economics Speaker Series. This evening, we have Dr. Wendy Heiger-Bernays, who is on the faculty of the Department of Environmental Health at Boston University School of Public Health. Her work reflects her education in molecular toxicology and professional experience in regulatory toxicology and risk assessment. Her interests center on understanding how environmental hazards adversely affect people's health and how risks associated with these exposures can be quantified and decreased. As part of the research of Boston University's Superfund Research Program, she works with scientific projects and leads regulatory, environmental, and health organizations to use the science to inform policy and practice. She also serves on technical advisory committees for toxicological and environmental health issues at both the Massachusetts Department of Health and the U.S. Environmental Protection Agency, and serves as chair of Lexington's Board of Health. Now, she has headed this committee for a number of years, and I've had the privilege of participating in one project about a decade ago, in which we were both associated with the issue. I can tell you that we are extremely fortunate to have someone of her caliber who leads our Board of Health, who has the knowledge, the experience, and the leadership talent to to deal with all of the health issues that this community has. And I am most pleased to be able to have her speak with us this evening. I assure you that she is a valued participant in our community as well as in public health. Wendy, it's all yours.
Thank you so much. Thank you so much, Mr. Burnell and Ms. Muir, for inviting me here to speak with you this evening. I am never bored. I take my research that Mr. Burnell shared with you and my science to my other job. That's my volunteer job as chair of your Lexington Board of Health, where I've now served for 4 terms. Here is where the rubber meets the road. Here's where we use the science to inform policy at the local level, but more on that later. I do want to say that my teaching is informed by my practice and my research. And one of my accomplishments of which I am most proud is having trained a generation of public health professionals. These people are in local, state, and federal health and environmental departments, and they are working tirelessly during this pandemic, but they are rarely thanked because they're not clinicians, they're not on the front lines, but they have served tirelessly. And many of them have stepped away from the field because of harassment, overwork, and lack of resources. So with that, we'll get started. And for tonight, we're going to do a little bit of an introduction. I'm going to walk you through public health. What is it? A little bit of history. After all, this is Lexington. We care deeply about our history. We'll talk a little bit about public health tools. And then, of course, we couldn't go without 10 minutes talking about this pandemic. So we're going to take a little bit of a tour. First of all, what is public health? So this fellow standing here is actually the dean of the BU School of Public Health. And I would suggest that the academic answer to this question, what is public health, is presented here. It's what we as a society do collectively to assure conditions for people to be healthy. It's really, public health seeks to promote health, prevent early mortality and morbidity, and enhance and ensure quality of life. And we must do that with a social justice lens. Public health is by nature a political issue. Most of the funding comes from government. And it also raises and addresses some very sticky issues, even here in Lexington. For example, sex trafficking here in Lexington. Other issues that you may not think about, cases of tuberculosis here in Lexington. And we also, in public health, balance the rights of the individual with the rights of the society to have a healthy, productive life. Another one of my favorite mentors is this fellow who passed away a number of years ago, Dr. Bicknell, who actually worked in the trenches. And he says, public health is the art and science of deciding who dies, when, and with what degree of misery. That sort of puts a little bit of a pin in the bubble, right? In the balloon. It isn't this high and mighty thing. It's how do we improve the health of people's collective lives? So what's the difference between public health and clinical health? So public health focuses on populations. We work with groups of people. We look at people often as statistics, which is often uncomfortable, a little bit icky. Another one of my mentors said, statistics are people with the tears rubbed away. Public health focuses on populations, and the emphasis is on disease prevention and health promotion. We employ a spectrum of interventions aimed at environment, human behavior, and even medical care levels. Clinical health is between you and your clinician. You have a medical issue, you go to your clinician, and the focus is on disease diagnosis, treatment, and care. So let me give you an example. A colleague of mine who had worked actually in a refugee camp illustrates the difference. She was taking care of women and children. Diarrhea was running rampant in the camp. She would prescribe medication on Monday, but the women and the children would be back the end of the week with diarrhea, sick again. The major cause of that diarrhea was sanitation, poor sanitation. So my colleague decided to give women, only women, all the women, bars of soap. This led to a significant decrease in cases of diarrhea seen at that clinic. Very basic public health principles have a major effect on the health of the population. We sort of say, like, clinicians may, tough job, hard job, but one mistake, you hurt one person. Mistakes in public health can hurt many. Conversely, and the positive, which makes me very passionate and uplifted, which is that in public health, we can help many people. So what are the things that affect our collective public health? Some of those things are things that we've known for quite some time. For example, the physical environment, right? So your physical environment, if you are living in a very, very crowded home and you have no access to clean water, you have little access to air in your home, clean air because you live next to a factory. The place is very noisy. You have neighbors who are playing loud music all the time. These can impact your health. Likewise, we know that the social environment, the economic environment, people's individual characteristics and health all impact our health. The interesting thing is, zip code is the greatest predictor of health. Lexington, we have 2 zip codes, but these zip codes, right, should be associated with good health. We're fortunate to have an excellent education system. We're fortunate with incomes and employment, community engagement, social support, childhood experiences, and all of these things come together in this niche called public health. And in order to maintain the public's health, what we need to do is to make sure that we deliver the public health services that allow our populations to thrive. But because of that zip code, we actually can take a little bit of a closer look, and we have learned that within those statistics, there are subpopulations within the larger population whose health is not as good as it should be, who suffer more so than others. We know that economics, we know that communities of color, we know that there are other factors that are particularly important in predicting the public's health. With that in mind, let's think about how a public health problem is viewed and how we might address it. we use something called the public health approach. And remember, the bottom line is prevention. We seek to prevent disease. And so there's sort of a history here. If we take something as straightforward as foodborne illness, and we all, well, maybe now we don't, we always fear getting sick from food that we ate somewhere, perhaps in a restaurant. And one of the things we normally think of when we think about a health department is restaurant inspections. So we actually can use the example of a restaurant inspection as illustrating this public health approach. We know that there are certain conditions where microbes that are found in food can grow and can grow enough so that if we eat that food, we can get sick. So we can actually define the health problem, right? The health problem is foodborne illness. We can identify the conditions under which that illness might occur in the restaurant. We can develop and test interventions. And for restaurants, we know that we expect that the restaurant, in the kitchen, that there is a sanitary code that is followed. The restaurant is clean. The food is kept either cold or hot or thrown away. And we use this intervention of these regulations, in this case, a sanitary code, to keep you safe. And then we have to make sure that it doesn't just happen once. We go back time and time again. In fact, twice a year to every restaurant establishment to make sure that those rules are being followed. Again, we do this to keep you safe. That is one very specific example with regard to restaurants, because it's so relevant, something that we know about. But initially, the public health approach that we have developed was focused on creating safe and healthy environmental infrastructure, really to reduce the spread of infectious disease. It shifted to focus on large-scale immunizations that we'll talk about later, and the newest public health movement addresses both ends of the spectrum with an approach targeting individuals, systems, and political structures. A little bit of the history of public health. Well, first of all, this is a chart, a graph showing us on the left axis, the percent of total deaths as a function of years starting back in 1845. These data come from the Massachusetts Department of Public Health, from the Registry of Vital Statistics. And as you can see here with the red line, that shows us the infectious disease, numbers of people dying of infectious disease as a function of year. Back in 1940, up through around sort of 1930 or so, there were significant numbers of people dying of infectious disease. You see a little blip in 1918. Anybody know what that corresponds to? Christine?
Maybe there was a flu around that time.
Maybe there was a flu. Maybe there was the very large pandemic, right? I didn't mean to put you on the spot. But nonetheless, the Boston, so we care a lot about history here. And it's really interesting to note that actually the Boston Public Health Commission was the first public health department in the United States. It was created in 1799 by Paul Revere himself. He was the first health officer in the United States. And it was because of him that we actually have this thing called local public health. Fast forward to 1869, And Massachusetts established its state health department, State Department of Public Health. And the early years focused on this issue of infectious disease, focused on isolation. Isolation refers to people who have been diagnosed with a disease and are placed at home. So isolation and quarantine. Quarantine are those people who have been exposed to the people who have the disease. And this is where we started. We started with smallpox and other infectious diseases, basic hygiene and sanitation. Wash your hands. Don't drink the water in which somebody else poops in, and things could get pretty good. It was also the time that we started to monitor epidemics, and you've all heard the word epidemic now. And so this all began way back in the late 1800s. And in fact, the first public health laboratory in the United States was founded in 1890s in Massachusetts. It's still operating. It's the up in Lawrence. It is the Water Quality Laboratory on the Merrimack River. That was where really public health got its start in this country. And it was during the sanitary movement. Advances such as water chlorination and filtration of drinking water, hand washing, vaccinations, all resulted in reductions in infectious disease rates by the 20th century. Although life expectancy in general has increased, as I mentioned earlier, for certain subpopulations, and we know that certainly for people of color, and people who face barriers such as people with disabilities, those gains are lagging. And it was at that time that we started to apply public health interventions locally. It addressed infectious disease with tools that had great effectiveness. And what those tools didn't address is what faces us today. That's the right side of the curve, where we see elevation in heart disease, in cancer, in chronic diseases, obesity, and diabetes. These are the chronic diseases that face us as a society. These are public health issues. I venture to say that most of the tools that we're applying in Lexington in public health did pretty good for the early problems. And if we were still back in 1930, Lexington would be doing great. I will suggest that we do need to update our tools to reflect the year 2021. And that is even at the times when we don't have pandemic. Moving on. Public health gets a lot more complicated, right? After we move from the sanitary movement, and all we thought about was things like hand washing, which is great, chlorination of drinking water, and infectious disease. We now know from all the research that has been done that social determinants, those things that you do that are not directly attributable to only the environment and genetics and healthcare, are actually a large percentage of what determines health. And if we look at the right side, so we look at this very complicated diagram, I want to draw your attention to the left-hand side, which says, living conditions are important for determining public health. We need to engage in community capacity building, community organizing, and engagement, as we're doing here. We need to recognize and develop our strategic partnerships in public health in order to develop policy to decrease social inequities that, yes, we do have here in Lexington and we have across this great nation. So there is a transformation underway in public health at all of these levels to partner with a broader group of stakeholders to address these factors. And the Massachusetts Department of Public Health is calling on local health departments to begin developing strategic partnerships in communities to tackle these questions. So how are we going to do that? What are the tools that we have in public health? How are we going to coerce or engage or require public health improvements? Well, let's step back a little bit. We actually have two tools to do this. One is government, right? Law and policy. An example of a public health law and policy is the Safe Drinking Water Act. The EPA sets the law, passes the law. The states are required to implement and require that public drinking water sources public drinking water meets those regulations. And at the local level in Lexington, every one of you who pays your water bill gets one of these lovely brochures every year. It tells you what the quality of your water is. It tells you that you are getting water that meets certain criteria. It will tell you whether there are elevated lead levels, which we know are neurotoxic to developing brains. And by the way, the next time you read that, you will see that the health director has signed off on that document. Our other tool, and there are other laws and rules that we have to follow. We have the sanitary code, which goes back to your restaurant, and a whole number of others that we'll talk about in a second. Our other tool is communication. Communication is a critical piece to convey, to educate, implore, and to get people to wear masks, right? And so we have to have these two tools. These are the tools that we use to address and intervene. So how is it set up in this crazy world of public health? Let's talk a little bit about the state and local public health systems. So it really is about government, right? Because the state statute, state laws, state statutes, regulations, and common law all give local boards of health authority to make decisions. The Board of Health is a policy setting board. That's what we do. We set policies. We adopt regulations that provide protections beyond the minimum standards that are set out in the Massachusetts general laws and the state sanitary code. And we set town-wide policy related to important health issues. And we'll talk about some of what those health issues are. So the Board of Health, which is what I serve on, I'm a volunteer. Lexington has a 5-member board, and we are appointed at different intervals so that the board doesn't turn over always at the same time. There is also a local health department. So Lexington has, like every other town, most other towns, a health department. We actually don't have a health department. We have a local health office. So the Board of Health is comprised of 2 medical doctors, 2 attorneys and 1 attorney who is a public health attorney whose work focuses on delivery of public health services to people with functional and access needs. We have a very competent board. And each of the 351 cities and towns in Massachusetts has a board of health. In some Western towns, small towns, the Board of Health also carries out the day-to-day function of the policy. In other words, you have to carry out the restaurant inspections. And for George, you have to carry out, years ago, inspections of the piggeries, any of the noisome trades. That happens on a day-to-day basis. In larger towns like Lexington, we have a staff of professionals, professional public health people who carry out the day-to-day operations, the policies, either given to us by the state or set by the Board of Health. And the municipal local health department consists of professional staff that act as agents of the local Board of Health to fulfill the statutory mandates on a day-to-day basis. And you want to make sure that when you pick up the phone, if you have a question, a concern, a complaint about any of the things I'm going to tell you about, that you get your questions answered, that the response is consistent with the policies set by the Board of Health. So, Lexington, we actually break down our local public health function into 3 convenient sort of categories. They're not hard and fast, and there is overlap in these. The first is community health. And as you might imagine, community health really is about, goes back to infectious disease, tracking, infectious disease follow-up, following the reportable diseases. There are 92 reportable diseases. So for example, if you have a foodborne illness, if you have Lyme disease, if you get a waterborne illness or some other communicable disease such as TB, pertussis, these diseases get reported from the laboratory or the hospital to the Department of Public Health and to the local Board of Health through an electronic system called the MAVEN system that you might have heard of during COVID. Community health also does surveillance of infectious diseases, chronic disease prevention, should be doing health screenings, should be doing health education, also medical waste collection. And some of you have benefited from the work of the board to institute medical waste. When you have medicines that are either expired or you no longer need them, prior to COVID, we were able to collect that medical waste. Water quality, tobacco, all sorts of things come under the jurisdiction, if you will, of community health. And in fact, just about 3 months ago, in the midst of the pandemic, the Board of Health adopted and supported the racism as a public health crisis. And we'll be working with many members of the community to address this issue. I'm I want to go back. Sorry about that. So also, we have environmental health. That's my area. I love this part because it's like everything falls into environmental health. It's the air you breathe, the water you drink, the food you eat. In many instances, environmental health is really hyper local. Many of you may remember the Estabrook schools with the PCBs. That's an environmental health issue. Lead poisoning in children because of old homes with leaded paint. Certainly a problem here in Lexington. And drinking water traveling through lead surface lines. We still have a few of those. So in addition, there are actually 19 environmental health regulatory programs that the public health oversees. Things like housing, food, swimming pools. People come to us for variants for swimming pools, recreational camps for children, nuisances. Your neighbor is making an awful lot of noise. The blowers, the leaf blowers. Big deal here in Lexington. Nuisance violation. Animals, whether they be raccoons or down here on the left, you see pictures of beavers. I bet you didn't know that the Board of Health grants a permit if beavers are obstructing a waterway and they have to be removed. Who knew? Noise, private wells, septic systems, body art, indoor ice skating rinks, tobacco. These are all in the purview of local public health and policies set by the Board of Health to either make sure that we're following the rules set by the state or we are more restrictive, more protective here in Lexington. And the last is actually emergency preparedness. Now, emergency preparedness is something that we are dealing with as we speak with regard to delivery of vaccines. People say, who expected a pandemic? Actually, the public health world expected a pandemic. We were planning for a pandemic, but resources were cut, significantly cut. And in fact, public health, when public health is working, you don't know it because rates of the disease decrease. It's only when we have a crisis that we recognize that public health is in trouble. And so let's continue here. I just listed here so you could see it, the specific obligations of the Board of Health. And let's increase the expanded problems which have become the purview of the Board of Health, those social factors that are facing us here in Lexington as well. So let's go back to this graph where we looked at infectious disease coming down very nicely. Our interventions are working, except we start to see an increase in chronic diseases, heart disease, cancer, obesity, diabetes. All of these make people more susceptible to severe effects of SARS-CoV-2, the virus that causes COVID-19. So we sort of set ourselves up for some problems because we haven't been addressing these chronic diseases. The same graph I added to the right there, a little bit of an increase, a big increase in infectious disease. These data, again, come to us from the Mass Department of Public Health. Let's talk a little bit about COVID-19 because it's been in our minds. Now, remember, look at the suite of obligations that the Board of Health has, even when there isn't a pandemic. So we want to make sure that in any day, take away the pandemic, that we have the capability to deliver public health services to you in all of those areas in an efficient and cost-effective way. Now let's overlay a pandemic. And yes, everyone is stretched. However, we have seen exacerbated the gaps in our systems. I'm not going to blame anybody because our common goal is to improve the public's health, and there's no time for any sort of blame. This is the typical graph that we see, right? You see this every week. What we see here on the top panel, number of confirmed deaths is a function of time. Number of probable deaths at the bottom as a function of time. We look at all these different statistics, right? We look at 7-day averages, we look at 14-day averages, we look at all sorts of statistics. What data do we really have, and how bad is it now compared to how it was back in March? And what do we do with this information? What do we do with these data, and how do we make decisions that allow us to respond to this pandemic, that allow us to protect the health of people, to prevent people from dying, and to prevent people from developing very severe disease? You'll recall that as this pandemic unfolded, we started to get some data. We had no testing. We dropped the ball on that one. We started to get some test data. Then we started to get some more test data. And then we got this term called the positivity rate, right? And we start to use this term as a metric for how bad things really are. Well, the positivity rate is a flawed statistic. It's actually not a term that epidemiologists have ever used before. It is a function of, call it non-standard and inconsistent testing. Many of us in Lexington have benefited from work environments that offer us frequent and reliable COVID testing. Other communities have no testing. And so if we look at this thing called positivity rate, and we have expanded or artificially inflated the denominator, we end up having a lower positivity rate, which doesn't really reflect the numbers and cases of diseases. So where are we in Lexington? So we've had 906 total cases. We've had multiple deaths. Most of them have occurred at the very beginning of the pandemic in congregate care nursing home at the very beginning of the pandemic. We have multiple people with severe illness, others not so severe. We still have questions about testing, and we have no clue about the variant situation. So we look to the state to help us out on that one. And I thought what I would do is look back over the past year, sort of a view of from the chair's chair here, where I've been sitting, like all of us, a lot. January 27th, 2020, previous health director, Cary came to me and said, we have a problem. That was when we learned about, it wasn't called COVID-19 at the time, but we knew what the virus was. And we started to talk about what might need to happen. Things happened pretty quickly. We needed to make some decisions. Remember, the board sets policy. The board gives direction. And we don't have the luxury of saying, we need more data. So I convened an advisory group made up of infectious disease epidemiologists, ID docs, environmental health scientists, and practitioners to discuss the knowns and the unknowns. We talked about masks. At the beginning, we said no masks, no masks, no masks, no masks. We had our first cases. They came from the Biogen meeting. Things started to get closer to us here in Lexington. We met with the school superintendent. We met with community leaders in town. Remember, this is a partnership, but they look to us to help with the health issues. So what do? We close the schools. A lot of decisions to be made. Many families have relatives in China. They were seeing what was happening there. So we held a town hall. You may have remembered, we held a town hall and we discussed what we would be doing. We then ultimately decided to close the schools. We did this. It wasn't a light decision to make. We did it. The next day, the state closed the schools. This is actually something that has happened multiple times, and the school superintendent and I have had many conversations about the fact that Lexington has really done an amazing job at making decisions with incomplete science, but using the best science that we could. We had a 3-hour public meeting on whether we should adopt a mask mandate in Lexington. 20 minutes later, the governor instituted a statewide masking mandate. We dealt with houses of worship, the farmers market. Remember, at the time, we were thinking about all of the surfaces that might be contaminated with virus and that we might become in contact with hands to mouth and become infected that way. However, we recognized that the science of airborne transmission was going to be very important. Federal government telling us, don't worry about airborne transmission. We knew we needed to worry about airborne transmission. We observed phenomenal work by our public health nurse, whom we share with Belmont, and the health director. They worked tirelessly at the nursing homes that had poor infection control, lack of adequate PPE, no testing. People died. Contact tracing, lots of great innovative apps, you name it. We're going to work with all these fancy companies. At the end of the day, it was theory versus practice. High tech versus shoe leather epidemiology. In Lexington, we don't use the contact tracing collaborative. We use the old school shoe leather epidemiology, and it is both a science and an art to get people to tell you where they have been and with whom they may have been in contact so that we can do the adequate contact tracing and isolation and quarantine. We had to discuss when testing became available, which tests would be useful, how to interpret the test results. Then the governor's order came, state of emergency in March. Essential businesses, which were they? How do we decide which ones they were? Well, we didn't decide, the governor says, and then the town administrator says these are essential businesses. There's a tension. There's always a tension, and a particularly here, tensions, we call them health versus wealth. How do we make decisions to protect the health while making sure that the economic engine of the town continues to run? But both factions need to be at the table. They need equal voice. And I would contend that you, as residents, would want us to be heard to protect your health. We then went on to policies on playing fields and the bike path. And let's not forget the bathrooms, the visitor center, and Lincoln Field. School reopenings brought, oh my gosh, we had the science of transmission of the virus, evidence. Was there evidence of in-school transmission? What was the impact on the whole child and the family? We had strong collaboration with academic colleagues, with the school superintendent, the school committee, and we worked through some surveillance and monitoring for some degree of in-person learning. The Board of Health worked through decisions in order to guide what was going to happen on the ground. And I will tell you that there are many parents who wanted in-school, full in-school. Others wanted only remote. We tried, we did the best that we could. We informed and guided schools on travel policy over holidays, right? We recognized that the travel policy of the state was based on convenience. It wasn't based on the science. Safety in town buildings. It's also our responsibility to protect the people who work in the town buildings. The Board of Health intervened to make sure that qualified consultants were hired to make sure that the air quality, the ventilation was adequate for both schools and town buildings. The work has been endless for many. The people of the health department, the health office have been working tirelessly, and we are 5 volunteers also working to improve the health function in town and provide public health services to those of you who live, work, and play here. And I'm going to wrap up because time is of the essence here with where we are now. We're all talking about vaccinations. People are happy to be vaccinated. And there are populations, and we will have to deal with this, populations who have vaccine hesitancy for past concerns, past decisions that have been made that have resulted in traumatic and very poor health outcomes in those populations. We all want to know, where can I get my vaccine? Well, Lexington, Arlington, and Belmont are partnering to deliver. We will have the Moderna vaccine. It's go back to the emergency preparedness, right? We are developing emergency plans that have an added degree of difficulty. We're doing this during a pandemic. We have to have social distancing and masking. We have to accommodate and make sure that people with access and functional needs get the same level of care and get their vaccines. So the Board of Health is the signing authority for the town's emergency dispensing site plan. We're working with the town to develop an acceptable plan. It's currently being rolled out. We are very pleased to have a public health professional, Robin Chappell, who is on board, who is assisting the town in writing and completing that plan. We're looking forward to signing off on it, and we've already implemented part of that plan. Oh boy, we've gotten 200 vaccines. We have a lot to go, but we're getting there. I want to leave you with, if you've gotten 1 vaccine, you're not fully protected. If you've gotten 2 vaccines, you are nearly fully protected, but you still must wear masks and distance, because you can get the virus and give it to others. And just because we have been vaccinated, we can't move about the country with no restrictions until we get a certain percentage of the population vaccinated. So what's next? I expect we're going to get a call about Patriots Day. Is it going to be a glorious morning, or are we going to get to go out there and stand with all those people again? schools, businesses, gatherings. We are now working towards figuring out how we're going to reopen by developing and implementing policies that protect health. So I promised you good, bad, and ugly. Good, response to COVID due to dedicated health professionals at the local level, the Board of Health, and committed, thoughtful residents. The bad, our communication about this pandemic was and is inadequate. And the ugly, I think our structure reflects the priority accorded to public health back in the probably 1980s. And we need to make sure that this is modified to allow efficient delivery of public health services. And I will leave you with the words of Dr. Fauci. Please watch the Super Bowl with your household and don't have parties. And I want to recognize my colleagues on the Board of Health, Dr. Bert Perlmutter, Dr. David Geller, Mr. John Flynn, and Ms. Sue Wolf-Fordham, and the Lexington Health Office, Mr. Alan Perry, who's acting health director, Mr. David Nealon, who is our public health nurse that we share with Belmont, Mr. Casey Mellon, and Ms. Alicia McCartan, health agents. That's all I have.
Thank you so much, Wendy. I did get a couple of questions in the chat, so I will ask those. I also want to apologize. I told people to raise their hand if they had a question, and we're not in a webinar, so you can't raise your hand. You can unmute yourself and I will call on you so that we don't speak over each other. So the first question that came up in chat was, what can be done to increase public and governmental respect and support for public health professionals?
I think the first thing is as we're doing here, is to recognize the work that is required and is done. I think it's making sure that you're, at least I think you're talking in Lexington, right? So
I think
we'll
so.
talk about Lexington. I think it's making sure that your neighbors know what is public health, what are the services that need to be delivered, that it is discussed that budgets are commensurate with the work that's required. I think that competence should be recognized in the administration, in the health office. We have some very good, competent folks. And I think that making sure that health is recognized as a key department or a key element of this town. Without our health, right, as they say, you don't got nothing. So where is the health department? Anybody here know where the health department sits? In the basement. Bring it up. Bring it up.
Wow. You would think that, yeah, visibility would be an issue, right? It's kind of a hidden job, I think, for a local Board of Health. So I actually told Wendy tonight, I said, tell everybody about the Board of Health and promote yourselves a little bit. So when you showed the graph with the causes of death in Massachusetts through 2017, somebody noticed that the injuries, the number of injuries increased significantly after 2001. And they asked if you had any thoughts on why that happened.
I'm sorry. Repeat your question, please.
On that chart with causes of death in
Yes.
Massachusetts, after 2001,
Yes.
injuries rose as a cause of death. Any thoughts on why injuries became?
Yes, many of those injuries had to do with worker health and safety injuries. So a combination of work injuries on the job, relaxing of a number of federal requirements played into that, as well as mostly it has to do with the worker health and safety issues for injuries.
Interesting. And did I remember correctly that it was since 2001? So that's nearly 20 years that regulations and workplaces have changed, so that contributes. That's kind of interesting over a long span of time.
Yeah.
I wonder if you were distracted because you noticed the comment in chat.
Yeah, I did.
The question, I've had enough of these programs. I can usually read what somebody's doing on the screen. So somebody says they're surprised that you think communication was poor. Why do you say that, and how can it be done better? Maybe give some examples on what kinds of communication.
Yes, absolutely. So I think what we always tend to do is we look at our neighboring communities, right? We want to make sure that we are, we're in line with what others are doing. If we take a look, for example, at a number of similar, either demographically or size-wise communities, or those such as Needham, Wellesley, Arlington, we look at their communication around COVID-19, for example. And what we see is that they are sharing information very frequently. They are sharing information about, about the disease statistics. They are sharing information much more that is more easily accessible. If you go to our website, our town website, you've really got to dig in there to find perhaps the information you might be looking for. We've improved. We've gotten better at displaying some data. You'll see Arlington modifies this every single day. If we look at Needham, we see that what they're sharing is the relationship. They look to see, where are the cases of COVID? Are they associated with workplace? Are they associated with in school? Where are they coming from? We don't share any of that information. It's not that we don't have that information. We just don't have I'll say the depth of the personnel to be able to make that available. Most departments of public health in sort of Eastern Massachusetts have a Twitter feed, or they have a Facebook page. I'm not going to go there, but they have a way of communicating. I would venture to say that most of the people on the call are unaware that the location that that we, for example, ran our a vaccination clinic today for 75 elders. We'd like to be able to communicate. And I think what we can do is we can set up a communication strategy, and we can, I think, be more independent as a health function than being tied to sort of the rest of the town. So there's a little bit more of a facile ability to get that communication out. Remember when I told you communication and education are the tools. People need to know. They want to know.
It's interesting that every town and every organization seems to be handling this whole situation a little bit differently. And I also think communication is an issue for all towns in all kinds of issues across the board. There are rules about archiving information, and so that makes social media a little bit of a headache for some towns. So communication is always an issue. So there's a question in here about when you think school-age children will be able to receive the vaccine.
So they are going to be way down the line, right? And so this is coming out of the clinical trials. Clinical trials were done on adults. They were not done on children. So, and this is not unusual in the way we do clinical trials in this country. So what we need to do is we need to follow the data from the clinical trials, and B, we know that we need to vaccinate certainly those who are older. They have more, as a population, the disease is more severe in those populations than it is in younger children. And I think realistically, we're not going to start vaccinating children until after we get well into phase 3. And there have been some trials that have come out of somewhere so that we can get the children vaccinated as well.
It makes sense. We want them to be safe from the vaccine too. So we need to test it, make sure that it will be safe for them.
Right.
Since there's no centralized system of patient data, for example, comorbidities, this slows down the process of vaccine distribution. Can you discuss the pros and cons of setting up such a database for the future?
So I don't know whether this is in reference to a publicly available database, which we will not have, but certainly there is no centralized system. However, right now, I don't think that this is what is necessarily slowing down vaccine distribution, because we're right now looking at age, right? And so we all have the ability to demonstrate what our age is. And I think for the comorbidities, what we're looking at right now is self-reported multiple comorbidities, which are additional underlying health conditions that make the virus more severe. And so I don't have a solution to that. I would look to my epidemiologic colleagues, those who study this, and then I could get you a proper answer.
And I imagine with a public database, privacy is an issue.
Oh, yes.
Even if it's just numbers, I think that the healthcare industry is very concerned about privacy.
That's correct. But when we started, we had very few numbers of cases in the state. We then started to increase the number of cases. And at this point, we are not looking at individuals, right? We are looking at, or specific individuals with name and residence. We are looking at numbers of cases, because we are now at a point where we can't tell who it is. So I think confidentiality was where we were at the very beginning. I don't think we're there now.
Okay. So the next comment that came in, COVID spread and vaccine development was known months ago. Why are we making plans now? What happened to July and August? And I'm not sure if that's in reference to the past July and August.
Oh, it was the past July and August.
Okay.
It absolutely was. And that would be from Jerome. Thank you, Jerome. You have hit the nail on the head. We were not prepared. We actually did not have the capability in town to develop those plans. We should.
Do you want to say anything about what gives you the capability to develop those plans?
Yes, people with the expertise, people, and there are such people with expertise. We expect, for example, that our teachers meet criteria. We expect that, everything that is done here, is done proficiently, that we hire competence, and we need to make sure that we put public health in a place where it is, as someone raised, is recognized and is respected, and then we'll be able to make sure that we have the competence in-house. I'm thrilled to say we actually, we're in a good place right now. I'm sitting pretty here.
We like that. I thought it was interesting when you said that the thing about public health is when it's working, you don't know it.
Correct.
So that makes your sort of public relations job very difficult, right? The
Yes.
education and communication is very difficult when it's working.
That's correct. And I think, when we're not in a pandemic, there are things that, they just get done. And some of them are sticky. They're really sticky problems because people are very complicated. But, I think that the communication piece is also part of the education, right? And We educate about a lot of things here. We need to be educated about what public health is and how to improve it for everyone.
How do you plan? How do you plan for something that is not yet known or seen? So when you were saying that the Board of Health has done pandemic planning prior to 2019, how do you do that? How do you play out a scenario and develop a plan? And how do you design it in such a way that it's actually useful to the community should you have to implement it, or
Well,
draw on it?
right. I actually think if we think about the basic sort of, we call them determinants of health, right? We know something about why it is that, people either might develop a disease or a situation may become problematic from a health perspective. So I think we're not actually starting in a vacuum. I think what we're doing is we're saying, okay, we've seen this before. We may not know exactly whether this is a physical hazard, whether it's an infectious disease, but what we do is we start to see some of the predictors of health. And certainly mental health is now certainly raised during the pandemic, but mental health is actually a public health problem. It has been divorced from the world of public health. But if we think about it, even in our clinical situation, right, often our health plans don't include mental health care. And so what we're seeing now is a recognition that mental health is critical to the health of the person and the health of the population. So I think the question about how you approach a problem that you haven't yet seen, I think we actually have some suggestions as to what we might look at. And then, we can go from there. So, and it's not done in a vacuum. Of course, you wouldn't, make this up. I wouldn't wake up one day and say, oh my gosh, look, we're the only ones who have this. It is likely that we would see it elsewhere.
Sure.
And the local boards of health actually do speak with one another. And so there are sort of regionalized units of local public health. And so, again, we wouldn't see it, only one problem and not see it anywhere else.
That's a good segue into another question, and then I'll go to the one that's in chat. How do you move from identifying something as an individual health problem to a public health problem? So for example, the Board of Health just voted to recognize racism as a public health issue right now. How do you get to the point where you see, even with COVID or HIV, when it's in a small population and then it expands, what's the criteria for naming something a public health crisis?
I think so whether it's a individual problem, right, is, so when we think about diseases, for example, right, if they're reportable diseases, or SARS-CoV-2 wasn't a reportable disease. At the very beginning, it wasn't a public health problem, right? It mushroomed into a public health problem when the numbers started to increase. So when we start to see numbers increase as a function of the total population, right, we start to say, oh, maybe there's something going on here. Mm-hmm. I mentioned early on, some of the things that we see, don't fall into the neat box of that's due to a bacterium in food, or smoking. Smoking is bad, and we need to increase our control here by decreasing the age at which young people can purchase tobacco. Right. And so that's an example where, did we have a problem? Yeah, we had a problem. Did the neighboring communities have a problem? Not so much. Right. And so what we did locally was we adopted, we thought about it. We thought about the implications. We ultimately voted to approve an an increase in the age at which you could buy tobacco. That's spread now across the state, and virtually for most of the state, I believe, age of purchase of, it's not just tobacco, it's actually nicotine delivery systems, right? Because it also covers vaping.
Yep.
And that wasn't a problem at the very beginning. It became a problem because young students, young children were actually being targeted by industry to start vaping with bubblegum flavored nicotine. Then they were addicted. So that's something where we didn't see a problem initially. We started to see cases that came up. And then we looked more broadly across and what was it a public health issue? I don't know that I answered your question.
You did. One last logistics question before we go to that one in chat. When the Board of Health votes on something,
Yes.
is there then another layer of approval that it needs to go through, either town manager or ballot or something like that?
So it depends. If we're going to change essentially a code, if we're going to change a regulation, right? So let's say we're going to raise the level of the age of sale of tobacco products. We do have to have a public hearing. We do have to go before town meeting for adoption. But if we're going to set a policy, for example, we're going to require that school ventilation systems be increased in capacity so that we do more filtering of the air, we can vote. We do not need to have a public hearing. We do not need approval by the town manager, but we do need approval by the town manager to allow the facilities people to actually implement that in the schools.
Sure. Yep. And so who do local health departments report to? Do they just report to the State Department of Health?
No, yeah. So ultimately we do report to the State Department of Public Health.
Okay. So I will make our last question one that I think is going to direct people to your website, but I'm not sure. How does one learn about how the vaccine will be administered in Lexington for older people? Is there a phone number to call or a website to go to?
You should contact, there will be only one number now, and it will be posted on the website. And I actually don't have it with me, but
I was all ready to put it in chat.
There are a whole lot of different numbers. I would direct you to Mr. Alan Perry, Perry. He is our acting health director.
Okay.
And he will be able to provide you with that information. It will be posted on the town website. And Mr. Sean Dugan, great voice. He is great. He told us, you know, make sure we don't put our trash out on Tuesday, but we put it out on Wednesday. And he will be providing information both on the website and when the time comes as a more general announcement.
And I can look up that information and send it out to everybody as part of our follow-up email that will also include the link to this recording and a survey asking you what you thought about tonight's program and what else you'd like the library to offer. So I am going to say thank you to all of you for coming tonight. And I'm going to say thank you to Wendy so much for this presentation. We got a couple compliments in chat already. And George, I'm going to unmute you and then put you on screen with Wendy in case you have any final words to share with us.
I would just like to thank you for your presentation. Very informative and very critical service that you and your committee serve this community. And I appreciate, I think we all can appreciate how much work and effort goes on that we never see or hear much about. So it's a pleasure to see you and to hear about the activities and to give our citizens an opportunity to ask a question they might not have otherwise. All done very nicely, and I appreciate your service to the town, and I appreciate your presentation this evening. Thank you very much.
Thank you. Thank you for having me, and we're here for you. We meet, our next meeting is February 23rd at 6:30 p.m.
And people can find that on the town website. There's a
Yes,
calendar
that
of
is
public meetings, right?
absolutely there. Yes,
So I imagine they're being held remotely still, but people can get that information.
correct.
I had told Wendy when we first met that I served on my town's finance committee for several years. And it's so important to get people to come to the meetings and hear the discussion that leads up to decisions so that you have that backstory and you get some questions answered. So check out the town calendar. And thank you again to Wendy and to George for bringing this program to us, and to all of you for coming. I hope you all have a good night and good luck getting your vaccines.